So, physiology of pregnancy. Pregnancy is a maternal condition of having a developing fetus in the body. The duration of pregnancy is based on gestational age. The gestational age is calculated in weeks, in the past months were used, and is measured from the first day of the last menstrual period. Last menstrual period LMP. It is divided into three trimesters. We have a full 12 weeks, a second trimester till 26 weeks, a third trimester from 26 weeks till delivery. Parity is defined as a state of having given birth to an infant or infant weighing more than 500 grams alive or dead. Nulli gravida is a woman who is not and never has been pregnant. Primipara is a woman who has been delivered who has delivered only once of a fetus who reached viability. Multipara multigravida is a woman who has completed 2 or more pregnancies to viability. The embryo is from fertilization to the 8th week. The fetus is from the 8th week till delivery. A fetus is considered viable when it has reached a gestational age of 23-24 weeks, survival chance of 50%, or a weight of more than 600 grams. A live birth is a complete expulsion or extraction of a product of conception from the mother. An abortion in the USA is the expulsion or extraction of all, complete or part incomplete of the placenta or membranes without an identifiable fetus or a fetus weighing less than 500 grams or with a gestational age of less than 20 weeks. It is 139 days from the first day of the last menstrual period. In European countries, the definition is confined to the termination of pregnancy before 25 plus 5 weeks, plus 25 weeks and 5 days. Uh, an infant is a live birth individual from the moment of birth till 1 year of life. A preterm infant is born prior to the 37th week of gestation. Immature infant goes from 20 to 28 weeks and the weight is between 500 and 1 kilograms. A premature infant is a birth weight in between 1 kilogram and 2 kilogram and a half, and from the 28th to the 37th week. Low birth weight infant when the weight is less than 2 kilos and a half. Small for gestational age is when the weight is undersized, less than 2 standard deviation for the period of gestation. A mature infant has completed the 37th week and usually is more than 2 kilos and a half. Post-mature syndrome, we have a prolonged gestation after 42 weeks, sometimes with excessive size fetus or diminished placental capacity for sufficient exchange. An excessive fetal size should be suspected in case of large multiparous pregnancies. Obese mother, mother with diabetes mellitus and greater weight gain than anticipated. Oversize if birth weight is more than 4 kilograms. Macrosomy, excessive size, meaning larger than the gestation would indicate, or would birth weights more than 4 kilos and a half. Neonatal interval is from birth until the 28th day of life. It's divided in 3 periods. First period is from birth through to 1 day, 24 hours. Second period is from 24 hours of life till 6 days, till 7 days, and the third period is from 7 days through less than 28 days. Perinatal interval is the span of fetal and neonatal life. is divided into two periods. The first one is 28 weeks of gestation, from 28 weeks of gestation to 7 days of life. Second one is from 20 weeks of gestation to 27 days of life. Physiologic changes in pregnancy. We have endocrinological changes that are pituitary gland, both the anterior and the posterior part, increase in volume. It's important to release oxytocin, which is fundamental for contraction during labor. Thyroid gland increases in size and activity. The thyroid binding globulin concentration doubles. Total T24 increase, but not free T3 and free T4. So, if you have to test a lady for thyroid diseases during pregnancy, ask for the free part of the hormones. Parathyroid glands, they increase in size and activity to regulate calcium metabolism. The adrenals, they increase in size and activity, there is an increase in total cortisol production. The placental hormones, progesterone and estrogen. Progesterone is produced by the corpus luteum and its level rises steadily during pregnancy. The main functions are reduction of colon activity, nausea, constipation, reduction of diastolic pressure, reduction of bladder and ureteric tone, venous dilatation, and raise in the temperature. It's normal to have 37.5 in pregnancy. The estrogens, early in pregnancy, they are produced by the ovary, later on by the placenta, estrone and estradiol, and by placenta and fetal adrenals, estriol. The levels increase up to term. The main actions are induce growth of uterus, development of breasts, alter chemical constitution of connective tissue, and water retention, edema, and reduce sodium excretion. Metabolic changes are carbohydrate metabolism. Pregnancy is considered a hyperlipidemic and glycosuric syndrome because there is a rise in plasma glucose concentrations, maintained between 4.5 and 5.5 millimoles per liter. Glucose crosses the placenta and the fetus uses it as primary energy substrate. The transport occurs by a carrier-mediated mechanism. The blood sugar levels after meal remain high, facilitating placental transfer. This postprandial hyperglycemia. Protein metabolism, positive nitrogen balance, and on average 500 milligrams of protein retained by the end of pregnancy. Blood and urea are produced. Fat metabolism, the concentration of lipids and lipoproteins in plasma increases appreciably during pregnancy. It's normal during the 38th week to have 4 kilograms stored in form of depot fat in the abdominal wall, back, and modest amount also in breasts. Cardiovascular changes are heart. The heart is displaced to the left and upward. The stroke volume rises. The heart rate rises synchronously by 10-15 beats per minute. Cardiac output begins to rise by 35-40% in a first pregnancy and 50% in later pregnancies. Hypervolemia serves to meet the demand of enlarged uterus and results from an increase in plasma and erythrocytes. The activation of renin-angiotensin-aldosterone system is necessary for the expansion of the plasma volume. The total extracellular volume rises by 16% and the plasma osmolarity is reduced by 10 milliosmolar per kilogram as water is retained. There is a fall in total peripheral resistance by 6 weeks gestation, reaching the nadir 40% by mid-gestation. Blood pressure. It slightly drops, especially in the second trimester. Small fall in systolic blood pressure, greater fall in diastolic blood pressure. The supine hypotension syndrome in the first half of pregnancy. Maternal hypotension occurs in the supine position, due to the pressure of the uterus on the inferior vena cava, decreasing venous return and cardiac output. So this compression of the vena cava leads to decreased venous return, decreased cardiac output, therefore hypotension. Noradrenaline, it remains invariant during pregnancy. For the pulmonary circulation, there is a progressive venous dilation and a rise in venous distensibility. So pulmonary resistance falls in early pregnancy. Pulmonary circulation is able to absorb high rate flow without an increase in pressure. Pressure in the right ventricle, pulmonary arteries, and capillaries does not change. Urinary tract changes. In the kidneys, they increase in size, the glomerular filtration rate and renal plasma flow increase. There could be a physiological hydronephrosis as consequence of hormonal progesterone and compressive factors. The uterus compresses the ureters, and this can lead to this hydronephrosis. Dilatation of the ureters, because the hydronephrosis may also be due to atony, so loss of tone of the ureteric muscles caused by progesterone, and relaxin that increased during the pregnancy. Vesico-ureteral reflux may occur as a consequence of the pressure of the uterus on the ureters. It's more common on the right side due to the extra rotation of the uterus. Frequency of micturition. The increase in frequency is in the first trimester due to the pressure of the uterus on the bladder, while later due to engagement of the head or back of the fetus. Urinary output. The extracellular water is increased by 7 to 6 liters during pregnancy. This is due to increased amounts of aldosterone, progesterone, and estrogen. 100 extra liters of fluid pass into the renal tubes each day. There is an increase in the tubular reabsorption. We have also gastrointestinal changes like ptyalism, increased salivation. Can be treated with belladonna. Taste often altered very early during pregnancy. Increased appetite and thirst frequent. So we have frequent small necks, heartburn caused by relaxation of the cardiac sphincter due to progesterone and relaxin. Emesis gravidarum, more frequent in the morning and during the 2nd to the 12th week of gestation. It's due to the levels of human chorianogona HCG hormone, which increase during the first weeks of pregnancy and reach the peak at 12 weeks. Then levels progressively decrease. It's produced by trophoblastic tissues. In case of dehydration and ketonuria, emesis requires hospitalization. So emesis gravidarum is due to levels of HCG hormone. Decreased gastric acidity. It interferes with iron absorption. Constipation. Reduced gut motility due to progesterone. This increases water and salt absorption. Liver. Total hepatic synthesis of globulins, so albumin, plasma globulin, and fibrinogen, increases stimulated by estrogen. Gallbladder increases in size and empties more slowly. Its relaxation increases the tendency of stone formation. Cholestasis may be dangerous in pregnancy, especially after 35th week, because it may cause fetal death. Pulmonary changes. Total volume rises by 30% in early pregnancy, 40–50% by term, and is driven by progesterone. There is a fall in expiratory reserve and residual volume, a decrease in threshold, increased sensitivity of the medulla oblongata to CO2. Elevation of the diaphragm in late pregnancy may cause dyspnea. The carbon dioxide production rises sharply during the 3rd trimester as fetal metabolism increases. The concomitant fall in maternal PCO2 allows more efficient placental transfer of CO2 from the fetus and results in a fall in plasma bicarbonate concentration. This altogether can cause a fall in plasma osmolarity and a slight rise in venous pH. The increased alveolar ventilation determines a small rise in PO2. Rightward shift of the maternal oxyhemoglobin dissociation curve due to the increase in 2,3-DPG in erythrocytes causes oxygen unloading to the fetus, which has lower PCO2, and marked the leftward shift of the oxyhemoglobin dissociation curve due to lower sensitivity of fetal hemoglobin to 2,3-DPG. There is an increase of 16% in oxygen consumption by term. Pregnancy places greater demands on the cardiovascular than the respiratory system. Hematological changes. Complete blood count. Circulating red cell mass increases by 20-30%. It rises more in case of multiple pregnancies and iron supplement. White blood cell count rises, especially polymorphonuclear leukocytes and neutrophils. The latter increase under estrogen stimulation. So we have a peak at 33 weeks, stabilization until labor when they rise sharply. T and B lymphocyte counts do not change, but their function is suppressed. Therefore, women become more susceptible to viral infections, malaria, etc. Platelet count and platelet volume do not change. Serum iron concentration falls, absorption, as said, from gut and iron binding capacity rise, and a concomitant fall in plasma folate concentration happens with renal clearance. Red cell folate concentration falls as well, but much less. Erythropoietin rises especially if iron supplements has not been taken, as a consequence of the decrease of hemoglobin, erythrocytes, and hematocrit. Coagulation. Factor 8, 7, 8, and 10 rise together with plasma fibrinogen. Protein C remains unchanged, important for hemophilic patients. The plasma fibrinolytic activity decreases during pregnancy and labor. It returns to normal values within an hour after the delivery of placenta. Diagnosis of pregnancy. Usually made on the basis of history of amenorrhea, enlarged uterus, and positive pregnancy test. The manifestations of pregnancy are divided in 3 groups. We have presumptive presentations, so symptoms like amenorrhea, nausea and vomiting, which usually occur from the 2nd to the 12th week, especially in the morning, and caused by some odors, caused by a rapid increase of HCG. Emotional tension may play a role. It may be a sign of multiple gestation or molar pregnancy. Treatment should be educational, light dry food, small frequent meals, high dose of vitamin B6, etc. However, if protected with dehydration and ketonuria, it may require hospitalization. We can have also breast changes with mastodynia and breast tenderness, that is tingling to pain, in response of hormonal stimulation, mainly progesterone, to mammary ducts and alveolar system. Can have Montgomery's tubercles, which is an enlargement of lacteal sebaceous glands which appear on the areola. We can have colostrum secretion after 16 weeks. We can have a secondary areola, that is a light pigmentation which appears around the first areola. Quickening is a first perception of fetal movement, which usually starts at 18-12 weeks. Sometimes it's not so simple to feel the movement up to the 25th to 26th week. It is less in multigravida. It could be misdiagnosed for bowel movement. Urinary tract changes are bladder irritability for decompression by the uterus, frequency, nocturia, caused by increased blood circulation and pressure of the uterus, urinary tract infections due to atony of the ureters, and also for the changes we have seen. In 7% of pregnancy is described as significant asymptomatic bacteriuria. Then signs. We have an increased body pressure, as said, normal up to 37.5. In the skin we can have chloasma, that is a mask of pregnancy. It's a darkening of the skin over the forehead, bridge of nose and cheekbones. We can have a linea nigra, which is a darkening of the nipple and lower midline and of the nipple and lower midline of the abdomen from umbilicus to pubis. We can have stretch marks that are striae of breast and abdomen from separation of underlying collagen tissue, adrenocorticosteroid response. We can have also spider telangiectasia, which is a common skin lesion from high levels of circulating estrogen. Probable manifestations are changes in pelvic organs like Chadwick's sign, which is a bluish purplish discoloration of cervix due to congestion of pelvic vessels, leukorrhea, that is hormone may increase vaginal discharge of mucus and epithelial cells. It's important to differentiate a normal leukorrhea from an infection. You can have Goodell's sign, that is cyanosis and softening of cervix, Ladin's sign, softening of anterior uterocervical midline of uterus, Egar's sign, which is a widening of the softened area of isthmus, McDonald's sign, which is a flexibility of uterus at the 7th week, von Ferdwald sign, which is a softening of the site of implantation. Bones and ligaments, we have a relaxation of pelvic joints, the symphysis, and ligaments due to progesterone and relaxin. Increased lumbar lordosis for compensating the weight of the baby and the gravity. The anterior position of the largic uterus shifts the center of gravity back. Can have abdominal enlargement due to divarication of the rectus muscle. To determine the gestational age, it's important to evaluate the level of abdominal distension. In fact, at 12 weeks, the uterus is palpable just over the symphysis. At 22 weeks, the uterus is at the level of the umbilicus. At 26 weeks, the uterus is at the xiphoid process. We can have also Braxton X. They are sporadic painless uterine contractions which start from the 28th week. They are felt as tightening or pressure of uterine muscle. We can have fetal movement from the 29th week until delivery. We can have uterine souffle. His auscultation after the 16th week elicits a rushing sound synchronous with the pulse, which represents the maternal blood in placental vessels. We can have ballottement of the uterus when the lower uterine segment of the cervix is tapped by the examiner's finger and left there. The fetus floats upward, then sinks back, and a gentle tap is felt on the finger. We can have also positive manifestations like fetal heart tones. The normal fetal heart rate is 120-160 beats per minute. Doppler devices can be used after 10 weeks, the 10th week. Palpation of the fetus after the 22 weeks. It's important to perform during the 3rd trimester the Leipold maneuvers. We have a first maneuver to evaluate the size and mobility of the presenting part. The head usually sharp, hard, firm and round. The buttock is soft and symmetric. Second maneuver is for the location of the fetal back. The back is firm and smooth. The extremities can be appreciated as firm irregularities. Third maneuver is for the pelvic inlet. The fourth maneuver is to determine if the head is well flexed inside the pelvis. Then we have ultrasound examination of the fetus. Ultrasound is the most used technique to determine the gestational age and check the well-being of the fetus. It can also be used to identify early pregnancy, demonstrate the size and growth of the amniotic sac and the embryo, identify multiple pregnancies, detect fetal abnormalities, demonstration of placental abnormalities, and you can determine with it intradecidual gestational sac between 29 and 35 days, gestational sac and Ilux sac at the fifth week, fetal pole and cardiac activities at the sixth week, embryo movement at the seventh week, the identification of gestational structures by ultrasound correlates with the levels of hCG. 1000 millieU per milliliter for gestational sac, 2500 millieU per milliliter for yolk sac, and 5000 millieU per milliliter for embryonic pole. There are alternatives to the ultrasound for estimating gestational age. The most accurate measurement for dating is the crown ramp length of the fetus, which can be done between the 7th and 13th week of gestation. After 13 weeks of gestation, the fetal age may be estimated using the biparietal diameter, which is the transverse diameter of the head, the head circumference, the length of the femur, the crown heel length, head to heel, and other fetal parameters. We can have fetal X-ray, still not performed because considered dangerous for the baby, possibly giving malformations and genetic abnormalities. It shows ossification after the 12th week. A fetal MRI is mainly used to check the well-being of the child more than the gestational age. Pregnancy test. hCG is the hormone released by the trophoblastic tissue produced by a growing fetus and associated placenta. Detection of hCG in maternal serum is evident only 8–10 days after conception, and in urine only about 23–24 days after conception. In general, the hCG levels double every 2–3 days in early pregnancy, peak at 10–12 weeks, and then plateau before falling. We have an home pregnancy test which detects the presence of hCG in urine sample, first voided urine sample. It's easy to perform. Change color, becomes positive, and has a sensitivity of 25–100 IMIU per milliliter. It's performed after the missed menstrual period, 4 weeks. You can have blood tests for hCG, useful only in special cases, such as bad obstetric history, abortion, suspicion of ectopic pregnancy, etc. They require special labs and expertise. Among these we have immunologic test, which is based on antigen properties of bhCG. The test uses direct or indirect agglutination of sensitized red blood cells or latex particle. Sensitivity from 250 to 3500 millieU per milliliter. It cross-reacts with LH. Radioimmunoassay is more sensitive in early pregnancy. Laboratory may detect serum level as low as 2–4 millieU per milliliter and can be performed in 3–4 hours. It does not cross-react with LH. And we can also have a radioreceptor assay. Calculation of gestational age. We can use a pregnancy calendar calculator. Put the arrow on the first day of the last menses and you obtain the week of pregnancy and the date of delivery. We also can use the Nagel's rule, that is, we subtract 3 months from the month of the last menses and add 7 days to the first day of the last menses. We can also use clinical parameters of gestational age, such as uterine size, quickening, fetal heart tones, ultrasound, and eventually X-ray. In some cases, not used in Italy, maturity can also be estimated by ultrasound or amniotic fluid analysis, which is obtained by amniocentesis. It evaluates the lectin-sphingomyelin ratio, which is an indicator of pulmonary maturity. When the ratio is 2/1, the fetus is mature. This is important for diabetic mothers. Diagnosis of fetal death is done by absence of fetal heart tones at ultrasound, reduction in blood ECG, absence of uterine growth. Late signs of degenerating fetus are overlapping skull bones, that is Spalding sign, growth in the great vessels, Roberts signs, exaggeration of the fetal spinal curvature or angulation of the spine. Antenatal care. Antenatal care means examination of the woman from conception till the birth. This is important to reduce mortality and morbidity, improve the physical and mental health of women and children, prevent and identify maternal and fetal abnormalities that can affect the pregnancy outcome. At the first visit, you can see the clinical history, so present pregnancy, calculation of ADC based on the first day of the last menses, regular irregular menstrual cycle, which may change the estimated date. Pregnancies, that is abortion, miscarriage, or premature delivery. Possibly she will have again a premature labor or C-section. Medical and surgical history, so thyroid disorders, which may cause miscarriage or premature delivery, diabetes, and so on. And a C-section may give the indication to perform again a C-section. Injury of the pelvis, surgery for the uterus, and genital repairs are indications for C-section. Then identification of risk factors like alcohol, cigarette, and occupational hazards, and review patient and family history for mental retardation or congenital abnormalities. So, for the clinical history, we assess the present pregnancy, the past pregnancies, medical and surgical history, identification of risk factors, and review patient and family history. General examination, we see weight, height, blood pressure, nutritional status, presence of edema. Edema is considered normal if in the feet and ankles during the day. The pelvic examination, we examine vagina and cervix, that is the Chadwick sign, blue-red passive hyperemia, dilated cervix, nulli gravida is 3-4 centimeters in length and no dilatation. In multigravida, it's little dilatation of the os of the cervix. Evaluation of cervical and vaginal lesion, discharge due to hormonal stimulation. It's important to exclude infections. Pelvis and uterus by bimanual examination. We see the pelvic inlet, that is the diagonal conjugate from the lower border of the symphysis pubis to the sacral promontory. The true conjugate is subtraction of 1.5 centimeters from diagonal conjugate, aka true anterior diameter. The mid-pelvis, we see the anteroposterior diameter from the lower back of the symphysis to the middle half of the sacrum. It's not measurable clinically. Pelvic outlet can be determined by palpating the pubic rami from the symphysis to the ischial tuberosity and noting the angle of the rami of more than 90 degrees. Transverse diameter is inner edges of B ischial tuberosity more than 8.5 centimeters. Abdominal examination allows the ongoing evaluation of the growth and status of the fetus, estimation of weeks of gestation, fetal heart tones, ultrasound lab tests, like blood tests, serological tests. There are some diseases such as toxoplasma and rubella, which can be dangerous for the fetus. Mental retardation if contracted during pregnancy. Also glucose test because gestational diabetes can occur after 24 weeks. The test can be performed earlier if there is family history for obesity, gestational diabetes, or if the woman is obese. You can also perform genetic tests, usually done over 35 years old or with abnormal pedigree, chorionic villus sampling at 10-12 weeks, and amniocentesis at 16-18 weeks. Urine tests to identify UTIs, proteinuria, and preeclampsia, which is a condition characterized by proteinuria and hypertension. Also do Papa Nicolau smear, and we buffer for group B streptococcus. It is done at or beyond 36 weeks. If positive, should be treated at labor to reduce risk of neonatal infection and sepsis. At the subsequent visits, we assess the maternal well-being, so the weight, blood pressure, fundal height, edema can be normal due to fluid retention. Sometimes it's a sign of hypertension. Fetal heart tones, fetal size and position, so Leopold maneuvers. Nutrition in pregnancy. Women should be encouraged to eat a balanced diet. The normal dietary intake is of 2,500 kilocalories per day, and the recommended of weight gain is of 11.16 kilograms. Weight gain is due to enlargement of the maternal organs, growth of the fetus, maternal storage of fat, and increase in maternal blood and interstitial fluid. Inadequate caloric intake may be associated with an increased risk of the fetal difficulties in utero and in low birth weight neonates. The main increase occurs in the second half of pregnancy. There is an increased weight of approximately 12.5 kilograms at term. There are different levels of gain weight tolerance. Underweight women can go up to 15 kilograms. Overweight women up to 10 kilograms. Obese women just to 7 kilograms. Nutritional requirements. We have proteins, especially important for cell growth. Calcium, necessary for ossifications of the bones and the fetus, for the mother and for the placental transport carriers. Iron, 36 milligrams per day. Supplementary iron is needed for both the fetus and the expanded maternal blood volume. The fetus maintains normal hemoglobin levels at the mother's expense. Vitamins, the most important is folic acid. The intake must be 400 milligrams per day. It reduces the risk of neural tube defects. The common complaints during pregnancy are thialism, as said, hypersalivation, pica, which is abnormal ingestion of junk food, abnormal frequency of urination, sexually transmitted diseases like syphilis, diagnosed by blood tests and treated with penicillin. Chlamydia can cause miscarriage or premature delivery in case it's acquired during pregnancy. Can be treated with metronidazole for 7 days. Gonorrhea, which is treated with penicillin. Herpes, which can be treated with antiviral drugs, but if lesions are present at the time of labor, it's an indication for C-section. Edema could be normal for the fluid retention. Diuretics cannot be used because they are teratogenic. The only thing we can do is lifting the leg over the abdomen. So diuretics are teratogenic. Varicose veins for the pressure of the uterus over the veins. Elastic stockings may be used. Leg cramps due to electrolyte, mainly calcium imbalance. And breast soreness. Matters of concerns during pregnancy. Dress. Women should avoid wearing tight clothes, such as belt or constricting bands on the legs, because this could impede lower extremity circulation. It's suggested to wear shoes with a low moderate heel to maximize pelvic tilt and possible backache. To minimize pelvic tilt and possible backache. We can have medications, immunization, they will cross the placenta and reach the fetus. Vaccines that are allowed are polio vaccine, diphtheria, tetanus, hepatitis B, and influenza. Varicella and MMR vaccines should be given 3 months prior or postpartum. Immunoglobulin if exposed to measles, hepatitis A, hepatitis B, tetanus, chickenpox, rabies. So, in case of exposure to measles, hepatitis A, hepatitis B, tetanus, chickenpox, and rabies, we just give immunoglobulins. Cigarette smoking. Vasoconstrictor action of nicotine can cause a decrease in perfusion of placenta, reduced appetite, and caloric intake. Alcohol. Not established the level of consumption that causes adverse effects. So alcoholic syndrome leads to mental retardation and mortality. Travel, move every 2 hours of stasis. There are no restrictions early in normal pregnancy. Dating pregnancy or travel plans should take into consideration the possibility of early labor. Sexual intercourse, it's allowed with moderation. It's absolutely safe and normal unless specific problems exist, such as vaginal bleeding or ruptured membrane. If a woman has a history of abortion, she should avoid sexual intercourse in the early months of pregnancy. Prostaglandins in seminal plasma and orgasm may cause contraction. Exercise not necessary, restriction except in particular case. It should be simple, like swimming and walking are ideal, but long period of walking should be avoided. Should be avoided also lifting heavy weights, long period of standing because it predisposes to varicose veins, sitting with legs crossed because it will impede circulation. Dental care, the teeth should be brushed carefully, gum hypertrophy and bleeding. A tooth can be extracted during pregnancy, but local anesthesia is recommended. No atrophy or adrenaline.